So switching gears for extensive stage small cell lung cancer, this is considered stage 4, where the cancer may have spread to areas outside of the chest, to the other area of the chest, to areas like the brain or bones or liver. And that is something that we do not treat with local therapies like radiation or surgery, but we add on our ways for infusions. So instead of chemotherapy alone, we are now adding immunotherapy, as you saw in 2018 and 2019, with the addition of atezolizumab or durvalumab for these patients. What we saw is that improved overall survival really led to a new standard of care in 2019 and 2020 by the FDA's approval. Typically, chemotherapy for extensive stage with immunotherapy is given concurrently or at the same time for 4 to 6 rounds, depending on the decision between you and the patient, the caregiver, and their doctor. This is typically 3 days in a row, every 21 days. And then after the scans are performed and permitting no spread or growth, then patients are switched to immunotherapy. And this is given continuously as long as it's working and the patient is doing well on therapy. You can see here, these were the 2 pivotal studies with Empower 133 and Caspian, as mentioned in 2018 and 2019 that were reported. You can see here with the blue bars compared to the yellow and red that there was an improvement and a flattening of the curve, meaning that patients who had a benefit, it seemed like it was durable. And what we know from the 5-year follow-up survival is it improves survival by about 10% for patients who have extensive stage small cell lung cancer, which was the first accomplishment that we had seen for many decades, which was the beginning of many accomplishments we'll see in this disease. For the treatment of small cell lung cancer, if it comes back, which unfortunately, as you can see here, we do see that the majority of patients do have the disease return, which can be quite challenging. And so small cell lung cancer is a very smart, adaptable cancer. And so we have to change therapies if the cancer returns and comes back. What we know is that there have been a breakthrough, as mentioned, in the last 4 years for how do we address this cancer and how can we do this in a smart fashion. So let's go through this data. So in 2020, we saw lurbinectedin get approved and an accelerated approval by the FDA based on a phase 2 study of 105 patients. Lurbinectedin is a unique chemotherapy. It's actually a semi-synthetic chemotherapy. It's an alkylating agent, meaning it binds to DNA and causes damage in the DNA. It's actually derived from the sea squirt, and it's a daughter compound from a drug called trabectedin. It is a drug that's given every 3 weeks as an IV. And what they found in the study is that 35% of patients who received this therapy responded, meaning their tumor shrunk and they had good disease control. What you can see in the top right is that there were some patients who had remarkable benefit, and we really need to know who those patients are so we can select those patients for this therapy. As you can see here, receiving 11, 13 plus months of therapy. I do want to, portray a personal anecdote here of a patient that I saw while I was in my fellowship. And this is a patient who was diagnosed with extensive stage small cell lung cancer. They received 4 cycles of chemoimmunotherapy followed by immunotherapy. And while on immunotherapy maintenance, unfortunately, their cancer did return, as you can see here in the bottom scans of the 3rd panel. And when that happened, the patient was switched to lurbinectedin right after it was FDA approved. And the patient received 24 cycles, where we know that real world data is about 4 cycles. Received 24 cycles, unfortunately had personal reasons that they had to come off of therapy. And now 2 years later they are still alive with no evidence of disease, doing well off of therapy for extensive stage small cell lung cancer. So durable responders to lurbinectedin do exist. And how do we find them? These needles in a haystack. We just saw the press release of IMforte, which is the role of moving lurbinectedin up into the maintenance setting for immunotherapy. And so how do we use this and sequence the best? And so I think seeing this data, we know that these are going to be released here in 2025, hopefully. And so with that, we want to know how do we use the tools in our toolkit in the best smartest fashion and the best combination that makes the most sense to give patients and their families the best outcomes possible. So stay tuned on this.